let me introduce our next speaker, Dr. Peter Kranz. I used to call him Dr. Kranz before I knew about him, and then patients would always say, no, it's Dr. Kranz. Is that right? Yeah, it's Kranz. So Dr. Kranz is a very wonderful, well-established neuroradiologist who practices at Duke with Linda Gray. And let me see what it says. He's an associate professor of radiology. He's the director of spine intervention. He went to Georgetown, University of North Carolina, University of Maryland. He's published more than 50 articles, and some of those are on CSF leaks. And he and I will tag team the subject of rebound intracranial hypertension. Peter.
So thanks very much. I'm going to be speaking for a few minutes on rebound intracranial hypertension, and then my friend Dr. Schievink, who has never had anyone mispronounce his name, will then tear apart all the things that I've said viciously. So rebound intracranial hypertension is a type of headache that can occur after blood patching, which is very confusing because most people who are getting blood patching are getting treated for headaches. And so if you have headaches and you get a blood patch and you have headaches afterwards, the first thing that people tend to think is, well, the blood patch didn't work or it needs to be done again or something like that. But as it turns out, these are different types of headaches. And they are characterized by headaches that are worse when the patient is laying down. And that is the most common feature. And they get better with sitting up, sort of the opposite of the typical low-pressure headaches. We have noticed that oftentimes, not all the time, but often the phenotype of the headache changes. So rather than having the typical posterior occipital headaches associated with CSF leaks, these headaches are often more frontal. And very often people will tell me, they feel the headache deep behind their eyes. Having nausea and blurry vision is common. And we started noticing some of these headaches, and many of these features are features that are very typical of actually high pressure. And so for some of the people with particularly fulminant types of these headaches, we did some lumbar punctures, and we found that there was a rapid increase in the CSF pressure in some of these people who we had just blood patched. Now, we reported, about 9 or 10 patients or so in a paper, but it's important to realize that the patients that we reported were just the people who we confirmed with lumbar puncture. And there's a lot of people who have these kind of symptoms to a lesser degree, who, we haven't confirmed with lumbar puncture, but still have the same symptom types, just not as severe. And it turns out that, many of these people, they will have a rapid spike in their CSF pressure, but sometimes that doesn't lead to an absolute increase in CSF pressure above the arbitrary number of 20 centimeters of water. But it's a relative increase. So you may have a patient who starts with a pressure of 3, and you push their pressure up to 18. They've been living at 3 for the past year, and suddenly 18 feels very uncomfortable for them, and they develop these rebound high pressure symptoms. The onset usually is in the first 24 to 36 hours after a blood patch. Typically what happens, the typical story is you do the blood patch, the patient goes home, they're laying down, which of course is when the high pressure symptoms are going to be worse. You make most of your CSF at night when you're laying down, and also because of the physics of laying down, your intracranial pressure goes up when you're laying down, obviously. And so they noticed, at 1, 2 in the morning, they wake up with these really terrible headaches, and they have nausea and vomiting and things like that. For many of these people, those headaches will decrease, after the first day or two, but sometimes they can linger, and on occasion, the headaches may not come on right away. Sometimes they come on days to weeks after the patch for reasons that really are not well understood. So just in a simple graphical form, you want to be thinking about intracranial hypotension when the patient gets their headache and they're standing up, and intracranial hypertension, rebound high pressure, when they're laying down. The intracranial hypotension headaches are worst in the back of the head, whereas the rebound headaches tend to be more around the eyes and in the front, although that, again, does vary. So here's just an example for those of you who've never seen a patient with this. So this is a patient who came in, had some brain sagging. The third ventricular floor is down here behind the back of the dorsum sella. The tonsils are down, but of course, having low-lying tonsils, there's a variety of reasons why that may happen, but there's only one reason, really, why your third ventricular floor is falling down out of your head, and that's a CSF leak. This was an MRI scan that she had 3 years prior. You could see that none of those changes were present. Her tonsils were not low-lying, and the mammillary bodies were elevated. So she had a CSF leak. Okay, so this is her myelogram, and this was done in the lateral decubitus position under fluoroscopy, and you can see there's this big irregular-looking diverticulum. That fluid is pooling independently, and you can see that streaming up from there is a leak of CSF. So obviously, she had a CSF leak. I did a patch on her. This is after I put the needle in, and then I put in the patching material right at this diverticulum. At the time of her initial myelogram, her opening pressure was 7 centimeters of water. Overnight, she went home, or she went to the hotel. Overnight, she developed these new symptoms. Headache worse when she was lying down. Nausea, vomiting, blurred vision, and for some reason, it's often the case that the headache is worse with laying down, and patients try to sit up, and then they get very nauseated. So they're sort of stuck because they can't sit up because they have nausea, and they sit up, and they can't lay down because they have headache when they lay down. So she came back into the emergency room, was admitted to the hospital. We did a lumbar puncture at 24 hours after her patch, and her pressure was 28 centimeters of water. Drained her down to 9 centimeters of water, put her on Diamox, watched her overnight. Her headaches were better for a couple hours, and then it came back pretty severely, so we repeated a lumbar puncture the next day. Her pressure was back up to 29 centimeters of water. Again, drained her down to 7. And progressively, over the course of the next couple days, her headaches became more manageable. We ramped up the Diamox, and eventually she went home. But that's a particularly bad case of intracranial hypotension, or hypertension rather, but other cases can look similar to that. So this is just a figure or a table from the 9 patients who we tapped. And I'll show you a couple things. So first of all, here's their pre-patch pressure, and here's their post-patch pressure. And you can see that some of these people had very dramatic swings. So here's a patient had 1 opening pressure of 1, and then it was like a champagne tap when we tapped them 2 hours after that initial blood patch. You can see some of these other people had pressure that went from 7 to 31, 15 to 32. So, and these are all within usually a couple hours or a day or two after the procedure. This one patient had been treated elsewhere for the blood patch, didn't have an opening pressure, but came to us being told he's got persistent CSF leak, did the opening pressure, and it was 28, and it turns out his symptoms were quite different than the symptoms he had at baseline. So many of these people have nausea and vomiting. Blurred vision tends to be fairly common. You can see this is present both in people who get fibrin glue and blood only, so it's not specific to any particular agent. Interestingly, it's not entirely dependent on the patch volume. This patient got 42 cc's, this patient got 5 cc's, this patient got 6 cc's. They all had pretty big spikes in their pressure, so it's not entirely dependent on that. And then treatment varies, 5 days, 6 weeks, 3+ years, 6 weeks, 6 months. Why some people have this last longer remains a bit of a mystery. So why does this happen? Well, like so much in this condition, we don't know for sure. We can speculate, and there are some possible mechanisms you can speculate about. One of those is just that you inject blood into the epidural space, and it acts like a blood pressure cuff on the thecal sac. It squeezes the sac, and just by doing that, you displace CSF out of the spinal canal and into the head. That seems reasonable, but it doesn't explain a lot of things that we observe. For example, the patient who got 6 cc's of blood and developed rebound high pressure, while other people can get 30 cc's of blood and don't develop rebound high pressure. So that by itself is probably not a convincing explanation. The other thing is that we talked about earlier issues with compliance, and there are probably compensatory mechanisms that people engage when they've been leaking CSF for longer periods of time. So one of those things may be that you increase your CSF production to try to compensate for the CSF that you're losing. And when you patch a leak or you shut down a leak or a fistula, those changes may not reverse immediately. So you may be overproducing CSF relative to what you need because you've plugged the hole. That's one possibility. The other thing is that we talked about some compliance issues earlier. We know that a variety of physiologic things happen in people with CSF leaks. We know that the epidural venous plexus dilates, and one of those areas is in the cervical spine. We know that that probably happens to some degree in the head as well. And that those compensatory changes, again, may not reverse immediately. There are differences in the epidural veins and intracranial veins from person to person. And so some people may be built differently in terms of their epidural venous structure. They may get more dilation or less dilation. And that may play a role into why some people get rebound high pressure and some people don't. How often does this happen? So I went back and I looked at the last 30 patients who I did a blood patch on. And for the past 2 years, I call patients the day after I do the blood patch just to see how they're doing, make sure they're not having high pressure. And for the past 2 years or so, I've been grading my impression of where they're, whether or not they have rebound high pressure. And basically, 0 is none, 1 is mild, meaning they have sort of a headache of 3, 4, something like that. I may put them on Tylenol, but I don't necessarily start them on Diamox. 2 is moderate, headache of 5, 6, 7, with the typical features of worse with laying down and better with sitting up, different phenotype than their pre-patch headaches. And usually those people I put on Diamox, and then 3 is severe people who have to be retapped or come back to the ER or come into the hospital. And you can see that about a third of these patients had no rebound symptoms at all. 43% of them had mild symptoms. Now, most of the time, these are pretty self-limited. They dissipate in a day or 2 or 3, sometimes a week, and then after that, no more problems. About 17% of them had moderate headaches, and then 2 patients, 7%, had severe headaches. And it's worth noting, I think, that both of these patients who had the real severe headaches had CSF to venous fistulas. And anecdotally, we have found that people with CSF to venous fistulas tend to get pretty bad rebound high pressure when you shut down that fistula. Now, none of this is stratified. Some of these people may have had bona fide leaks, some may not. some of them may have been leaking for longer periods of time. We know that the changes that we see on imaging are partially time dependent. So the dural enhancement we see with brain MRIs, the longer you've been having symptoms, the less likely you are to see those dural enhancement changes. So we know that intracranial hypotension is probably not a single static state, but that it actually changes over time and evolves over time. So none of that is baked into this analysis. This is sort of a first pass. But it is fairly common, and you just have to be aware of that and be on the lookout for that. I was on call 2 weekends ago, and there was a patient who came into the ER who had a CSF leak a year ago or so and was successfully treated. And she developed some new tinnitus. She was a little freaked out that she might have a recurrent leak, so she came to the ER. And I was talking to the ER physician because they were going to get an MRI, and he said, you know, you may not realize this, but some of these patients who get blood patches, they can get this thing where their pressure bumps up after they get sealed. And I just want to make sure that she doesn't have that. And it's a good thing that we were on the phone, because I would have kissed him on the forehead. Because, you know, for a long time it was a challenge just to get people to believe that this is a real phenomenon, that it happened. And now here was an emergency room physician who not only knew it existed, but was thinking about it when the patient came in. Turns out she didn't really have rebound high pressure, but just the fact that the awareness had gone up, I think, was a major step forward. And the fact that I didn't kiss him on the forehead saved a lot of awkwardness. So how do we treat this? And this is something that, you know, I think this is opinion. It's in evolution. Different people may have different perspectives on this. But basically, this is sort of the way I do it. If it's mild, I'll have the patient elevate their head. Wedge pillows can be helpful to do that at night. And then, you know, some, basic analgesia, Tylenol or something like that. Reassurance that in a couple days this tends to wane and go away. And that's true for most, but not all people. If it's in the moderate range, we'll typically start the patient on acetazolamide. I've found, and I think Linda, my partner, has found too, that IV acetazolamide can be very helpful immediately, usually within about 10 or 20 minutes after getting. Some of these people we see in the recovery room, and they already start to report these symptoms of high pressure. And occasionally even on the table. You know, you patch them and suddenly they're like, whoa, my head feels like it's going to explode. And they can feel immediate changes. And so we'll give some IV Diamox and then start oral Diamox, and that for a lot of people is very effective. Other meds that, you know, people use, topiramate, Lasix, HCTZ, other diuretics. Nortriptyline has been, you know, anecdotally reported to me as being helpful. None of these things obviously have randomized clinical trials behind them. We're a far way away from that. So I think, you know, there are probably even some other strategies that people have that they find to be effective. And then if it's severe, oftentimes, you know, we'll do a lumbar puncture to bring down their pressure immediately, and then start them on the aforementioned medications. Everybody has their own secret sauce for how they deal with this, but this is sort of how I conceptualize it. So, so that's, yeah, sure.
How many of the people with rebound hypertension have papilledema?
So that's a good question. We don't always check for that. I would say that the times that it is checked for, it is often not present. And nevertheless, when you tap these people, their pressures are elevated, and when you remove fluid, their symptoms abate. So I don't really, I'm glad you asked that question. I meant to say something about it. I don't really think that, I mean, obviously if they have papilledema, that's helpful, but the absence of papilledema wouldn't dissuade me from.
Have you published that?
What's that, the papilledema?
The lack of it. Because I sort of have a hobby of idiopathic intracranial without papilledema, this would be further evidence of the.
Yeah. We have not published it, but I think that's, that's sort of a controversial topic, but I think a lot of us in the room would agree that there are people who have high pressure, and where high pressure begins is hard to define because it's probably not related to a single number. And also, many of those people will not have papilledema. I think,
Can I just make one comment?
yeah.
That one patient that had a pressure of 55 centimeters of water was checked 3 times because that patient was actually hospitalized because it was difficult to control her pressure, and she had to get every other day LPs for a while. She was checked 3 times for papilledema, and her pressure was over 55 and kept gradually coming down. Never once had papilledema. No.
You've got to.
Yeah, question?
You measure ultrasound, there's a direct methodology to measure ultrasound, the open nerve sheath, and I can give you some more than 5 millimeters. It can give you a very close correlation to it measure. So we're doing now, those patients monitor by looking, if we have symptoms present, we do ultrasound very quickly and have a look.
Yeah, that's an interesting question. We haven't. I mean, we've been treating patients based on symptoms. A lot of times it's straightforward. They have these stereotypical headaches, they're high pressure type headaches, and you treat them. But it can get very difficult sometimes. I mean, sometimes it's hard to distinguish what's going on with headaches 3 months, 4 months afterwards. Some people are reluctant or not. They're not available to get a repeat pressure measurement. So yeah.
It's possible that sleep is involved in some of this mechanism. If you, there's pretty good speculation that the blood-brain barrier is relatively incompetent in patients with sleep apnea, that there is a marked excitotoxicity that goes on in the cortex with sleep apnea, and those patients develop a coagulopathy, making resorption more difficult. And this is present for idiopathic intracranial hypertension. By extension, that may be the reason some of the patches fail, but may be the reason also that that this post-patch hypertension exists. Just thought.
Yeah. So I mean, I think that there's a lot of different routes for investigation into this, and I think it will be informative to get some more information about what happens with the physiology of the CSF after you do a blood patch to somebody. What happens to the compliance? What happens to the CSF pressures? That's something that we're sort of dipping our toes into the water of now.
I've seen a number of patients with this rebound intracranial hypertension after either patching, or actually one patient that Wouter had operated on had severe rebound hypertension with papilledema. I was even concerned that she might actually lose her eyesight because of that. But the real question is, how do you decide when to stop the therapy? It can be kind of challenging because oftentimes they're still left with some headaches, and knowing when to stop, unless you repeat an LP to see what the pressure might be.
Yeah, so that's a good question. I mean, so what I usually do is, depending on how severe their high pressure is, their symptoms are, I will just taper them down. So, if it's mild, after 5 days, I'll start to have them taper down on the Diamox, and if things are doing okay, then you taper them down and they come off. If they start tapering down and they're doing worse, then you have to go back up. There are some people who, you start them on 1 dose of Diamox, they're still having headaches, you have to step up their Diamox, and if they're getting better as you're stepping up the Diamox, it probably means they're high pressure symptoms, and some people, they may not get better when you step up the Diamox, and they may have, coexistent parallel headache pathologies and other things like that. So sometimes it's trial and error.
Thanks.
So do you see rebound intracranial hypertension in patients who have post-LP blood patches?
Yeah, so the answer to that is yes. But there does seem to be, I would say anecdotally, the people who have been leaking for longer periods of time tend to get it worse, right? So there are we see this subset of people who have had a post-LP headache and they've been patched 2 or 3 times and it's been ineffective. And those people tend to be the people who you see rebound high pressure on. If you have somebody who's just been leaking for 24 hours or something like that, yeah, they can get a little bit of rebound high pressure, but it, in general, tends to be less of a problem than other people.
What dose do you try to rebound?
I start with 50 milligrams IV, and that tends to be pretty effective. You could repeat that, for a second dose if you wanted to. But yeah, and then usually I'll start them on, if you're giving them IV Diamox, it probably means their symptoms are a little worse, and so, you can start them on something like 500 BID of the oral Diamox. If it's mild, I might start with 250 BID or something like that, or if they're getting it particularly bad at night, you go up to 500 at night. You kind of have to tweak it a little bit and dial people in.
Thanks, Peter. Just to digress quickly back to the papilledema, knowing that the fluid around the optic nerve sheath and the connection with the CSF and the flow dynamics inside there are slightly slower. I don't know how much slower. How long does it take, do you think, for a patient to develop papilledema with rebound?
I don't know.
And that
Again,
might go
we
with regards
haven't.
to the limited patient,
Yeah,
55.
I have only, a few patients who we've actually looked for the papilledema because it hasn't really changed our management. And my sense is that there are some people whose optic nerve sheath communicates better with their CSF space and transmits that pressure better than other people. And so some people just don't develop it. But even if you look at MR scans of people with pseudotumor, with IIH, not all of them will have that dilation of the optic nerve sheath. Some of them will, but some of them won't. And so, there's probably some person-to-person variation that makes that sort of an inconstant sign, which is why I would say if they've got papilledema, great, but that is informative. But if they don't have papilledema, don't think that should lower your pretest probability that they have rebound high pressure.
20% of patients with chronic migraine with without papilledema have increased intracranial pressure.
Yeah, I think that and that's even if you just use the arbitrary definition
250.
of 250. So I think there's, we're talking about the lows, but we could probably have a whole conference about the mysteries of the highs too. All right, Dr. Schievink.
Thank you, Peter. There was a terrific talk. I don't think we disagree on too much at all for a change, but what I did want to say is that, we do a lot of blood patches on people who we suspect of a spinal fluid leak, and they get a really bad high-pressure headache after the blood patch. That does not mean that they had a leak, right? So I think for most of us, especially if we would get a high-volume blood patch, we're going to get some bad high-pressure headache if we did not have a leak to begin with. So we've seen that. I saw my first patient with rebound intracranial hypertension back in March of 1994 when these fine gentlemen ruled the world. And it was a patient who had an 8-year history of orthostatic headaches. He had an MRI, brain sagging. He had actually, I think he had surgery for his Chiari. Then he had a CT myelogram. This is when I was a resident at the Mayo Clinic, and he had a single L2-3 nerve root cyst. And we operated on him and put a clip on it. And then, post-op, he was a lot of narcotics from his laminectomy. And then a few days later, I was making rounds, and he said, "Oh, Doc, my headache, it's not any better. I still have a headache." And it was maybe, whatever, the 10th patient we'd seen. And we said, well, probably the surgery didn't work. And he went back to another state. And I think we talked to him a couple of weeks later, and he said, I still have a headache. But then about a month later, he started complaining of visual loss. And he went to see an ophthalmologist, and he had bilateral, really bad papilledema and a retinal hemorrhage. And then this high-pressure headache just gradually resolved. But then at that point, we started asking him, oh, what about your headache? And he said, well, you know, I still have a headache, but it's sort of the reverse. That, you know, we had, of course, you know, we'd never heard about that. And then when we published this, you know, our first 10 patients with spontaneous intracranial hypotension, he was actually like, you know, the infamous illustrative case report. So that was, you know, 1 out of 10 people. So sometimes you'll read that the prevalence is 1 out of 10 people. Now, how is that now, right? I mean, obviously, there's a lot more known about rebound high-pressure headaches, but, you know, there's, like Dr. Kranz said, there's so much that we don't know about it, right? What is the frequency? Some people in Italy have said the frequency is 0. I usually say it's about 20%. The treatment, you know, usually Diamox. What else? One thing that we do use, and usually people laugh about it, is that we'll tell them to get some dandelion tea. That's a very mild diuretic. You know, there really are no good diagnostic criteria for that. So we thought a few years ago that we would study this in a little bit more detail, and we looked at 113 patients with spontaneous intracranial hypotension. For diagnostic criteria for rebound high-pressure headache, we said it has to be a reverse orthostatic headache, right? So just like what Dr. Kranz told you. So the headache has to be worse when they're laying down. It has to be better when they're up. If they don't get better after a few days, I have a pretty low threshold for Diamox, so their headache must be better after Diamox. And then, you know, the not better accounted for by another cause of headache. So you have to make sure that those patients don't have, let's say, venous sinus thrombosis or something. And then 2 of our neuroradiologists scored the MR venograms. And there's a paper that was written in 2004 by a British radiologist, I believe. And it's a score where if your MR venogram, if the lateral sinus, the transverse sinus, if it's normal, you scored it as a 0. If there's 1 or more areas of focal narrowing, you score that as a 1. And if there's a complete signal gap, you scored it as a 2. And that's sort of what this looks like. So this one over here, this sinus we thought was good. This one has a little bit of focal narrowing, so we give that a 1 and a 0. So you add the score, so that's a 1. Number 2, so this there's a signal gap here. You score that 2. This one looks good, so that's a 0. And then this one, gap here, that's a 2. Focal narrowing, that's a 1, so then you get a score of 3. We did not see any patients with a score of 4, and that's what you typically see in people with idiopathic intracranial hypertension. So most of these patients were women, like in most series, and we found that 31 of them, so about 1 out of 4, met these criteria for rebound high-pressure headache. So even though Dr. Kranz and I, we did not discuss this before we gave this presentation, so it's like almost identical as his 24% of patients who had, you know, significant enough rebound headaches that warranted treatment with Diamox. When we compared the people with the rebound headache to those without the rebound headache, we found that it was more common in women, it was more common in the younger age groups, and it was more common in those who had an obvious leak on their spine imaging. About half of these people did have fundoscopic exam, and only 2 of them had papilledema, 1 of them with a little hemorrhage. But, you know, these are not, half of the people were not examined by an ophthalmologist. Oftentimes it was, you know, their neurologist. It might have been one of our neurosurgery residents. But anyway, but only 2 of them had papilledema as far as could be documented. And then also what seemed to be related to whether or not people have rebound high-pressure headaches was this MRV score. So for those people who had a normal score of 0, or I don't even want to say normal, the people who scored 0, which was 42 out of the 113, 14% got rebound headache. The ones who scored 1, about 24%, The ones who scored 2, 44%, and then there are only 3 who had a score of 3. 2 out of those 3 people developed a high-pressure headache. So we thought it was pretty common after treatment. About 1 out of 4 people get this. We didn't really see any relationship with the type of CSF leak or the duration of symptoms. But, it's only 100 patients, so who knows? And then it seemed to be related to age, sex, presence of whether or not there's an extradural CSF collection, and then it looks like the venous anatomy on MR venography. So for those patients who have this for a very long duration after the rebound high-pressure headaches occur, you could consider, stenting of the area of stenosis. Of course, after you do an angiogram and you see that there's a large enough pressure gradient. But out of these 113 patients, none of them had that done. We do have one patient who had that done, I think, a few months ago and did really well. And I was going to put in a shunt in her, and she didn't need to have the shunt. Now, I don't know if stenting is better than shunting, right? They both have some risks and some benefits. Thank you.